Our next speaker, who I'm happy to welcome, is Ms. Karen Boucher, Senior Medical Illustrator and Editorial Graphics Manager for the Journal of the American Medical Association and other publications of JAMA Network, and faculty member of the Biomedical Visualization Graduate Program at University of Illinois at Chicago. She is also an active professional member of the Association of Medical Illustrators, where she recently served on the Board of Governors and a board-certified medical illustrator. Ms. Boucher is joining us via Zoom today to talk about visual communication for journal publication.
Thank you so much. I hope that you can all hear me. Thumbs up, hopefully. So first I want to thank Ian and Francois and everyone at QU Netter for inviting me to celebrate with you. I'm coming all the way from Chicago, where it is cold today. So today I'm going to talk about my contributions to the visual communication of research and clinical content that's published in JAMA, where I'm a medical illustrator. So today I'm going to give an overview of our department, which is called Editorial Graphics, talk about the medical illustration workflow within journal publication, as well as the impact of what we do. So here's a quick peek at my background. I actually have a painting degree as my undergraduate. My family also tried to talk me into medical school instead of art school, and they were like halfway successful, I guess. I do want to point out I'm also a professor at the University of Illinois at Chicago, where I teach grad students in the biomedical visualization program. And I'd like to say hi to them because they were also graciously invited to the symposium, as this is right in the middle of my class time. So thank you so much. And thankfully, I'm not alone at JAMA. I work with 3 other illustrators, Andy Rakito, Lohitha Kathu, and Nick Reback. And all of the work I'm going to show today is by one of the 4 of us. We all have master's degrees in medical and scientific illustration, and together we create approximately 400 original figures per year for publication in JAMA. We're called editorial graphics because we have editorial power. So that means we actually have a seat at the table and we decide what illustrations are published to enhance the content of JAMA. So our department has been around for over 20 years and we review the submitted content that comes into JAMA. We create custom medical illustration. We examine data presentation and style. We tailor figure and graphical content for our audience. And we're also trying to stay competitive in the market. One of our biggest competitors, New England Journal of Medicine, also has an in-house staff of medical illustrators. I would say both teams are really working to create original content in a cohesive branded style for each of the journals. So everything that we create is published in the print version of JAMA, which is a peer-reviewed weekly publication with a print circulation of about 200,000. And our web journal is now actually considered canon, and it was redesigned to prominently feature our illustrations, which we really liked. And all of our work also appears on social media. So we have lots of modes of publication that we have to consider when we're creating an illustration. And what kind of work do we actually do? So I'll start off with editorial illustration for our medical news and perspectives section, which are articles written by an in-house staff of medical journalists. So this is where we really have the most opportunity to work in a variety of styles. And personally, this section is where I like to workshop illustration styles. I keep a huge Pinterest page of cool illustrations. So this is where I try out new things that wouldn't necessarily jive with medical illustration or traditional medical illustration. We also create custom covers for our theme issues of JAMA. So we also have quite a bit of stylistic freedom for these, and throughout the process, we're working really closely with our editor-in-chief, or if there's a guest editor for the theme issue, to make sure that we're producing a visual that they really feel represents the topic. And then on to our traditional medical and scientific illustration. First up is the patient page, which is on a new topic each week, and it always appears on the last page of the journal. And these are eternally free, which is a great feature of these. They're in every single issue of JAMA, so we always have patient pages to work on. And as the name implies, these are for a patient audience rather than that general clinician. And the focus is really to enhance and define the patient's take-home message. We're also producing patient pages for 6 of our, I believe, 12 specialty journals on a monthly or quarterly schedule. So here are some examples from pediatrics, dermatology, and JAMA oncology. The really fun ones are the big scientific illustrations for scientific articles, meaning clinical trials, often mostly reviews, but sometimes special communications or other clinical content as well. So these are often the big complex illustrations that are going to complement and enhance the content of the article. These are created for that general physician audience. They can be molecular or cellular or at the gross anatomical level, or sometimes some sort of combination. And they can also incorporate visual data. But throughout this process, which I'll walk through here in just a moment, we're working carefully with our authors to ensure that we have an accurate outcome. And then we have data visualization, which includes visual abstracts. And these are really meant to be a snapshot of our randomized clinical trials. So it's really just a visual interpretation of that abstract that's being published with the OI. And these appear only in social media and the web journal. We also create algorithms and other data displays that might incorporate illustration, like this one on diabetic foot ulcers. And here's one on glioblastoma. But they can also be diagnostic or treatment algorithms for use in the clinic. And I want to point out that everything we do, we're approaching every illustration through an intersectional lens. The AMA has actually charged all employees to embed equity in everything we do to advance health, racial, gender, and social equities. That's actually one of my job objectives. So because we're the visuals of JAMA, we have the responsibility to build trust and create visuals that are relatable to people across identities and experiences so that we can better communicate science and medicine. I'll move on to the medical illustration workflow. This is, as you probably know, a peer review workflow. So we've got a manuscript being submitted there on the left, and then it goes to a preliminary review. About 77% of JAMA's articles are rejected during this point, and the remaining are sent out for peer review. If an article is accepted, then it goes through an extensive editing process. It gets formatted and scheduled for publication and sent out to the printer. So I actually contribute to the pre-acceptance review process by completing content and technical review, and I evaluate manuscripts for figure opportunities. And then after a manuscript is accepted, I'll either assign the figure to myself or one of the other illustrators, and we begin that creative development and production part of the process. So during that pre-acceptance phase, our authors come to us with a wide range of figure submissions, and sometimes there aren't any, and we actually suggest that an illustration or figure would help clarify the data. So we ask for a figure legend at a bare minimum, but more often we get some sort of sketch or figures built in PowerPoint or anything. And these are actual examples of figure submissions here, but our goal is to really hit the ground running once we have an accepted manuscript. So here's a rough outline of the 3 parts of figure creation, and I hope you'll notice that the bulk of our time is really spent in that researching and concepting and content refinement versus actually creating the artwork. That all comes at the very, very end of the process. During that researching and concepting phase, we're going to first look at the submitted materials. So this is pathophysiology of COVID-19, and the submitted figure is there on the upper left. We do tons of research looking at other papers, other articles. We might look at histology images, radiology images. We have content experts we can talk to. And we actually have the JAMA Illustration Archive, which at this point has over 10,000 illustrations in it. So we can use assets from those images or just use them as references as well. And from all that, we'll create a concept illustration, which is there on the lower right. And you'll notice that the illustration components are actually very simple. They're very sketchy. And this is all on purpose because our goal here is to get all of the text and didactic elements, which you can see in there. Those should be accurate way before we actually start on the art. And a lot of that can change. So we want to keep the art very simple, but really nail that story. So then we work on refining the content, which is really just a lot of back and forth between the illustrator and the authors and the editors to make sure that everything is accurate. We start to work piecemeal on the artwork as components of it get solidified, really, and anything that's still in question. So here on that bottom panel, there was still a lot of questions about that was late stage COVID, and this was like March of 2020, so we didn't really know a whole lot yet. A lot of questions to be answered, so that part's not as finalized yet. And then once everything is done, we move on to that final artwork. It's approved by the author, reviewing editor, manuscript editor, proofreading, and then within our department as well. So again, here's the example from the submitted artwork on the left to the published artwork on the right. Hopefully some improvement there, but still that one was really beautiful as a submission. But what you'll see in the submitted versus published is that we add a lot of context. We're trying to tell a really complete story with our illustrations. So this one's on knee osteoarthritis. And then on this one for carpal tunnel syndrome, all that was submitted was that median nerve distribution. So in order to tell a more full story, we added a lot of the anatomical context, diagnostic testing, as well as treatments. And then I'll move on to our impact. So believe it or not, this fairly boring figure is the second most important figure I have ever created, and I'll get to the first in just a minute. But this is Q-SOFA. This is the bedside screening tool used to identify patients at high risk of poor outcomes from sepsis. And this was published as part of Sepsis 3, which was the third international consensus definition for sepsis and septic shock. And to date, it has nearly 4 million views and 12,000 citations. So an incredibly important paper that I actually got to contribute a really boring figure to, but a really important figure. And I do want to touch on a favorite project of mine, visual abstracts, which I developed along with Andy Ricchito, because these are one of the few figure types for which we actually have a lot of data. So you can see that we designed them to be really similar to the JAMA cover in style and color, and we still create these for all randomized clinical trials that are published in JAMA. So we tracked the data and we compared 21 randomized clinical trials published with visual abstracts and 21 without in the same 6-month time frame. And average usages for articles with a visual abstract were twice the usages of those articles without, in 18,000 versus 9,000. The altmetric score, which is a measure of article views, media reports, and social media usage, also improved for trials with a visual abstract, 231 versus 283. So all of this means that our visual abstracts are really helping to get this important clinical data in front of more people. We also had a really unique vantage point on COVID-19 because we were like really knee deep in the research. So these are two important figures for clinical review articles on COVID treatment and then the pathology. So the image on the left I actually made over a weekend in April of 2020. And that highlights what were then the current treatments under investigation and how they interrupted the viral life cycle. And only one of those treatments is still in use, which is remdesivir. And on the right is that illustration you just saw that Andy created to show the pathophysiology of early and late stage COVID as it was understood 3 years ago. So we spot our work all over the place in a variety of media, and we really appreciate being valued by our employers and the community. It's really gratifying to see the impact of our work. I'm going to end here with a quick story of a firsthand account of the impact of our work. And I want to let you know that I have full permission to share this because this is me and my mom. And less than a month after this photo was taken on Christmas Eve of 2019, my mom went to the hospital experiencing all the classic symptoms of a heart attack, except that she went under extensive testing and it showed she wasn't having a heart attack. So she got a heart cath and it showed minor blockage in her left anterior descending coronary artery. So doctors put in a stent and she was home the next day for Christmas, which should have been the end of the story. But unfortunately, her chest pain continued and developed so that she couldn't even walk down the hall without running out of breath. Before she could get back in for her scheduled repeat heart cath, she ended up back in the hospital. And these are some actual texts sent between me and my parents around that time. But all the testing and an angiogram continued to show that her heart was fine and her coronary arteries were clear. Her doctors were baffled. She's in rural Indiana and they couldn't find a reason to keep her in the hospital. But I just couldn't let it go because right before she was hospitalized, JAMA had published a pair of papers on coronary microvascular dysfunction, or CMD. A JAMA Insights article for physicians on the left and an accompanying patient page on the right. Now, if you're not familiar, CMD is an underdiagnosed, often overlooked disorder that typically occurs in women. Rather than a more obvious blockage in a coronary artery, patients with CMD have damage to or blockages in the coronary microvasculature, and that causes symptoms of chest pain, shortness of breath, and exercise intolerance. Treatment of CMD controls pain and breathing difficulties. It lowers the chance of worsening symptoms, and it prevents future heart attacks and heart failure. But first, you have to be diagnosed. Now, according to the authors, 2/3 of women who present with symptoms of ischemia have no evidence of obstructive coronary disease on angiographic evaluation. They're told their heart is fine and they're sent home. These women are 10 times more likely to develop heart failure, and 8% of these women with ischemia who have an inconclusive angiogram nonetheless die from a cardiovascular cause within 10 years. This JAMA Insights article by Wei et al., Coronary Microvascular Dysfunction Causing Cardiac Ischemia in Women, for the first time recommends and provides a new protocol algorithm for physicians to diagnose CMD. An algorithm that was designed, organized, and edited by me. So a few weeks before my mom started experiencing symptoms of CMD, I actually worked with the world's leading expert on CMD to develop and write the protocol to diagnose coronary microvascular dysfunction. So I sent this over to my mom's doctor and I pleaded with him to not send her home, and he used my figure to diagnose and treat my mother for CMD. So this figure doesn't look very exciting. It's an unimportant design for a non-major paper on an overlooked pathology, but it had a part in saving my mother's life. So that's why, to me, this is the most important figure that I have ever created. My mom's doing great. It's 4 years later. Her heart is healthy, and all thanks to the dissemination of medical research and maybe a quick thinking daughter. But I'm not alone. Every person that Medical Illustration impacts is someone who works with people and lives with people and means something to someone. Everything that we create has the potential to affect the life of a real person across identities and experiences and those who love them. And I'm incredibly honored every day that I get to do my job. So thank you again to the organizers and staff at QU Netter, and I really appreciate the opportunity to present to you all today.
So Karen cannot us very well, so I'm going to take questions for her and I will let her know what they are in the microphone. Dr. Payne.
So are the JAMA images, the JAMA artwork, separately searchable from all the ones?
Karen, did you hear that?
Yeah, I can hear that.
Oh, all right.
Not actually, yes. I think on the website, if you do a search, you can actually click figure as one of the parameters in the search box. But I will be honest, we actually, when we switched to remote learning, we lost access, like easy access to our archive. So I just use Google to find all of my old illustrations to this day.
Yes.
Actually, thank you very much about sharing that personal story, because you just reminded all of us how important it is to get focused on things that they are private but important very much at the same time. And coronary microvascular dysfunction, especially for women, is a big, huge issue. I just looked at colleagues that they are doing research in Europe regarding identification as early as possible and to get treatment. I think I will look for that image, what you have in JAMA. And if I can search now, I think I will share with them as well. And I think this is a unique case that you are educating us as well. Thank you so much.
Thank you. Appreciate that.
Please.
Yes.
Given that your work is based on submitted manuscripts, who owns the illustrations?
Sure, it's actually the American Medical Association. I will say, like, I mean, the examples that I showed are just a couple, but what we end up illustrating looks nothing like what's submitted, like 98% of the time. And often, like I said, often nothing is submitted, or it's just a figure legend. And the authors that we work with, they know we exist, and we're offering that service as part of, it's a perk of publishing in JAMA.
It's really just a.
Sorry, I was.
It's really just a comment, but it just seems that this is such a natural extension of Frank Netter's work, right? It's exactly what he was doing throughout his career. So it is, taking his work, expanding that to our current times. So thank you.
Karen, thank you. That was such an informative presentation. And I have to say, as a reader of JAMA, I've been very appreciative of the greater degree of representation in your illustrations, particularly on the patient page. I've really noticed that. And you always come back to, when you appreciate something like that, learning later the intentionality. So hearing about how the AMA was embedding equity, and then actually noticing the result of that. So thank you for including that intentionality piece of it, because I think it's important for all of us to remember that those things don't happen just by chance. They really require intention, strategy, and so forth.
Thank you. I appreciate that. It's it was already implemented before I even started working at JAMA, as far as including diversity within our illustrations, but we've made a really big push over the last couple of years, especially just broadening beyond just skin color, showing people of different ages, different body sizes, different ability levels is all super important.
With respect to the illustrations, either you or your team create, to what extent is hand drawing involved in the process?
Great question. When I started, I was still doing all my sketches in pencil and scanning them in. That was about 10 years ago. I still do a lot of thumbnailing, just idea building in a sketchbook, or even Post-it notes, to be honest. But we all work on Cintiqs, which are big monitors that you can draw directly on. And I think at this point, we're doing most of our sketching digitally. I don't think anybody's scanning in anymore. So everything's in Photoshop and Illustrator.
Yeah, I just want to point out the difference between hand drawing and digital versus analog. It's still hand drawn. This is not a computer that does that. I think that's important to realize.
Yeah, and we're still, as Dr. Luke's saying, we're drawing everything by hand. This is my pencil right here. I just draw on a monitor, and we do occasionally build assets in 3D, but we build them into our illustrations. So I had to do a little desktop calendar recently, and I just built it in a 3D program, and then so I didn't have to draw it from scratch.
Any other questions? Keep thinking, I was seeing hands going up, so I hope this looks good. Karen, thank you so much.
Thank you so much. Appreciate it.
Very happy to introduce Ms. Mika Ford as our next speaker. She is a board-certified medical illustrator and founder of Enlight Visuals, scientific and medical visualization studio. She creates inclusive illustrations and 3D visualizations for scientific research, journal publications, medical education, and patient educational materials. She received an MS degree in biomedical visualization from the University of Illinois at Chicago and a BFA in studio art from Georgia Southern University. Her goals include improving health literacy through visual communication and contributing to the growing need for inclusive and diverse representation within medical and healthcare literature. She's based in Atlanta, Georgia, and is currently the chair of the Diversity Committee, the Association of Medical Illustrators, and a co-organizer of New York City. Side is NYC, a scientific visualization conference. Today, she's sharing with us the multifaceted language of medical illustrations.
Thank you so much. I'm honored to be here today. I wanted to start out by giving a brief land acknowledgement and state that I acknowledge the indigenous peoples and nations, including the Tlingit and other Algonquian speaking peoples that have stewarded through generations the lands and waterways of what is now the state of Connecticut. I honor and respect the enduring relationship that exists between the peoples and the nations. So today I'm going to be talking about the multifaceted language of medical illustrations. And just to give a quick overview of what I'm going to be discussing today, I'm going to be talking about the various visual approaches that I take to science communication, the impact that they have on both academia and the general public, and how medical illustration can be used as a catalyst for health equity. So to kind of give you a background about who I am. So I've been an artist pretty much my whole life. 3 or 4 years old, I was drawing and painting as a kid, and my parents really fostered that within me. So what I did was I ended up studying fine art at Georgia Southern University. And while I was there, completing my BFA degree in studio art, I became really fascinated with human anatomy and nature, and I saw a lot of connections between nature and our own anatomy. And I started to depict that with my paintings that I would create. And one of my illustration teachers saw my work at the time and told me about the field of medical illustration. And I knew right then and there that that's exactly what I wanted to do. I took a very traditional path into this career at medical illustration. And so what I did after that, after I graduated with a fine art degree, I was a part-time postdoc student for a couple of years where I took science courses. So to get into a graduate program, I needed a background in both art and science. And since I had the art, I needed the science. So I took some classes at Clayton State University as a postdoc. I then went on to University of Illinois at Chicago. UIC is one of the 5 accredited schools that gives a degree in medical illustration, a graduate degree in medical illustration. So I graduated from there in 2017. Shortly after that, I moved to New York City and I worked for the Icahn School of Medicine at Mount Sinai for about 5 years. And as of late, I'm now a full-time self-employed medical illustrator. I started my company this year called My Visuals. And the reason why the line continues off the slide is because I really think of this as the start of my journey. So I'm gonna go on to visual approaches that I take to science communication. So while I was working at the Icahn School of Medicine at Mount Sinai, I collaborated with clinicians, medical students, research scientists, and medical students to create illustrations that were published in journal articles, presentations, patient education material. And I also collaborated a lot with the faculty and staff there working within medical education to create illustrations that were lectures and course content material. And so I'm gonna be going over a few of the visual approaches I take to medical illustration and why I make these choices. I really liked that Mike and Francois were talking about simplified illustrations earlier and the difference between detail and simplification. I'm gonna be discussing that with schematic illustrations and also talk about rendered illustrations and why I take different approaches to simplify work as opposed to highly rendered detailed work. So this is just kind of a snapshot of the kind of audiences that view my work, and then the deliverables in this context is where that medical illustration ends up living after it's completed. So to start, I'm gonna go over a couple of schematic illustrations that I've done. With this illustration, a research scientist and his colleague came to me. They were studying Alzheimer's disease, and they were looking at different genetic pathways involved in a disease and developing a novel therapeutic drug that in hopes of treating it. So this was very complex information in science. And so when I worked with them, basically what I did with this schematic was broke down the different steps. They were analyzing a lot of data, as you can see. And so I had to break it down and simplify it in a way that just kind of parsed out what was most important to show. And then I used lines and arrows to kind of connect that information and show the direction. So this is a schematic, a diagrammatic schematic that kind of breaks it down at science and simplifies it and makes it easier to understand. Same thing with this project. So this one, I want to show a little bit more of the process. The woman I was working with was studying genetic variants in chronic pancreatitis. She was also another research scientist. She actually had a very clear idea of what she wanted. And a lot of times I'll have clients that will provide me with a sketch, which is very helpful for me. Takes a lot of the load off when they kind of already have a very clear idea of what they want. So these are her sketches right here on the left. I took her sketches, I made them more concise and put them together in one figure and showed this most important information that she wanted to show, and then colorized it, and that was published in the textbook there. And so kind of with complex science, taking a schematic illustration approach, I'm making a figure that is aesthetically pleasing, but also just shows the most important information for the viewer to understand, and just makes it a lot more digestible. This is another example of a schematic that I did. It summarizes the different levels of brain function that were being studied at the Friedman Brain Institute in New York. And then this was published in the Frontiers of Medical Science, which is actually a supplement to Science magazine. So switch gears a little bit and talk about the rendered illustration. So with this example, if any of you have seen the art show already, this is actually one of my pieces that's in the art show upstairs. With this illustration showing the Google Fact Pad, I did decide to make this a rendered illustration because it was very important for the viewer to understand the surrounding anatomy. And not only that, but also just the detail in the muscles and the tissue textures and the difference that those make in comparison to the Google Fact Pad. So with this, for example, gross anatomy, things like surgical illustration, maybe editorial work, I will take a rendered illustration approach. For this illustration, this is 3 different steps to the blepharoplasty procedure. This is an example of a surgical illustration. And I usually include pretty fine details with surgical illustrations because the viewer in this case was ophthalmologists and other plastic surgeons. The exact detail and location of the sutures was very important for them to understand, as well as the difference of the adipose tissue texture comparing that to like the muscle and fascia texture. So this is another example of why I took a rendered approach to this. And I just have one example of 2D animation that I did. On occasion, I'll do 2D animations. This is actually a GIF animation, so it's very short and sweet. But basically, I was working with a faculty member to explain hair cell transductions in M1 students. And for this one, I decided to show the mechanical electrical transduction with this hair cell on the left-hand side that's animated. It's very simplified because we just wanted to show just the basic simplified information for the student. And then we decided to animate that process so you can see what things happen simultaneously and what things happen in order. Here's an example of some of the 3D work that I've done. This is also a project that I did when I was working at Icahn School of Medicine at Mount Sinai. And the faculty member in this case was teaching about cranial nerves. If you studied cranial nerves before, you know they're not the most easiest structures to understand. And so they wanted to show these in 3D so the students got a really good idea of how that nerve takes that pathway to the skull, where it branches out. And so doing that in 3D, this is actually posted on a website called Sketchfab. It's a 3D platform that allows you to upload 3D models. So the students were able to use this in class and get a better understanding spatially of how that nerve moves through the skull. Same thing with this project. So, for the same anatomy course for medical students, learning about the inner and middle ear. I created this using a 3D sculpting program called ZBrush. And this was also another very complex structure, you know, and so having that available for students to rotate and kind of zoom in, look at labels in 3D gives led for a much better understanding. So I'm going to talk about the impact now in academia and public health. So kind of like I was just showing before, and as medical visualization as it relates to student learning, what I've noticed is that medical illustration in the context of medical education reinforces medical students' knowledge of complex anatomy, and especially being able to view structures in the three dimensions gives them a more spatial awareness that they're not going to get from a 2D illustration that's in the textbook. And also, medical illustration also has the power to improve medical and healthcare literature. So for this project, I was working with a surgeon and he was writing an article about a BKA procedure, which is the below the knee amputation procedure. What he was doing was comparing a previous technique where certain muscles were spared. And then with this paper is writing about particular muscles which were different that he spared in his novel technique. So I did an illustration discussing this and comparing these two ways of doing the procedure. And after I completed it, he actually called me and told me that he rewrote some of the text describing the image in the paper before publishing it, because it made him realize that it wasn't described clearly the way that he wanted it to be discussed in the paper. So for me, that was really touching. It was one of my first projects actually that I had working at the medical school to impact medical literature in a positive way like that. And also medical illustration is not always used just for didactic purposes. This is a textbook cover that I did. And the purpose of this cover was to captivate the viewer, to draw them in, no pun intended, to get them to want to read the book. And so I chose to depict a Black woman in this cover image because I also noticed that through my studies, I had seen a lot of people of color on textbook covers or inside them as well. And just having that representation just has a very positive impact in promoting inclusivity in healthcare. And this was another project that I did earlier this year. I was working with a creative agency called Wonderman Thompson Center of Excellence. And this project is a digital zine that we worked on together to create that talks about weathering. So weathering is a word used to describe the cumulative burden of stress and its effect on the body over time. And what they were doing was looking at weathering in the context of Black maternal health. So with this zine, zine includes medical illustrations as well as animations and poetry about lived experiences of Black women in the healthcare system in regards to Black maternal health. And so it got a lot of positive feedback. If you want to check it out, it's at ruckus.com. The website link is at the bottom. And it really amplified those voices of lived experiences of Black women in their journeys to motherhood. So it's very impactful for them. And so that brings me to the last section of my my presentation about medical illustration as a catalyst for health equity. So this graph is from an article that was published about 5 years ago, and it is comparing 4 major textbooks used in medical schools. And on the left-hand side, you can see that they were looking at individual depictions of race in clinical textbooks. And you can see that Gray's Anatomy is really the only one that has about an equal representation of white people of color and Black individuals in the textbook. The rest have more overrepresentation of white bodies in the text. But if you look on the right-hand side, they did the same study, but this time they looked at skin tone and not race. And you can see that even when, for example, race, even when there may be an even representation of race, there's still an overrepresentation of lighter skin, even when there's different races depicted. So that's a stark example of colorism. That basically has a lot of negative effects in the healthcare system. And what I kind of want to talk about is a lot of bias and stereotypes can develop from underrepresentation and lack of representation of people of color, people with darker skin who have been left out historically of medical visualizations and depictions. And what I've also noticed too, as well as lack of representation of race, there's also historically been a lot of anti-fat bias as well in medical illustration. So favoring the thin, lighter skin, athletic body kind of marginalizes everybody else that does not fit that mold. And so one of the things I focus on with my work is trying to break that. And as well as different types of body sizes being represented is also important. Things like blemishes, stretch marks, asymmetrical features, those are all very normal as well. And so Inclusive medical illustration, like ones with darker skin or ones with tattoos, can eliminate those bias and stereotypes in healthcare and the healthcare system. And healthcare providers, what it can do is change their attitudes and perceptions so that it's more well-rounded and all-encompassing of all different kinds of bodies. And in their training materials and things like that, that can really lead to more effective and empathetic care. And so, when viewers see medical illustrations that resemble people that look like themselves or, you know, resemble or reflect their experiences, they can feel a stronger personal connection to that work. But it also leads to increased engagement and better understanding and retention of medical information and material. And so for this illustration, I'll discuss this one a little bit. This was for a patient resource that I did on when to change your central line. And this was also at the medical school I worked at. And I chose to depict it and split the image in 2 different skin tones because the patient population for this illustration was very diverse. And so I wanted those different people that saw this to be able to see like the different symptoms and how they present on the skin tone that may be closer to their own. And as you can see, redness presents a lot differently on darker skin. And so medical illustration this way, it can empower individuals to make informed decisions about their health and well-being. And it also fosters a greater understanding and engagement in the information, and it really plays a critical role in narrowing health disparities in that way. So I hope that one of the things you've gotten from my talk today is just the breadth of medical illustration and different kinds of services that it can provide. And thank you so much. And the QR code if you'd like to see further and answer questions. Well done.
Thank you for the great presentation. So my question is, in clinical trial, we know that's predominantly white patients are almost like 80–85% nation. So do you think that medical illustration has some impact or can have some impact changing that in clinical trial?
I think it can in a way that it could get maybe participants interested to participate. I think that historically, people of color don't usually volunteer to participate in clinical trials because of the disparities and kind of some of the egregious treatment that's happened historically in our medical healthcare system. So it could maybe in a way be used to kind of like promote the trial or make people feel more comfortable to participate in the first place.
So to all illustrator, my personal request would be do a social marketing campaign to change the mindset participants in clinical. Because this is a huge issue everywhere, NIH, Science Foundation.
I like your presentation. I'm learning a lot how you help to make all these applications to be much more useful. And it seems like this whole work that you do is very time consuming. And if you're working with, you know, a specific person or surgeon or any faculty member or anyone, and you are helping to that application, especially with the text content as well, adding your algorithm with your visual input, are you becoming to be one of the authors, or how this is appreciated after your input?
I'm sorry, can you repeat the last part of the question?
Do you become to be one of the co-authors for that publication?
Oh, usually not, but I have been listed as second author a couple of times. It's not usually standard practice for a client that I'm working with to list me as an author, but in certain cases, they'll just offer it, which is really nice. What I do always do is just ask to be acknowledged and obviously cited in the publication, which they always do, but yeah, it's always nice when a doctor physician I'm working with offers to list me as the second author. Yeah. It doesn't happen often, but it's nice when it has.
That's amazing. What did you do?
Thank you.
I was curious as you're creating illustrations that are going beyond the norms of what we've seen in medical illustration, but well within the norms of what we see in society. So for example, having people who are obese represented. And so my question is, how do you don't have a reference point. There aren't as many illustrations or photographs or any other representation there. So how do you extrapolate what you know? I was thinking about the woman, how far up does the adipose tissue go, and how do you make those decisions?
Yeah, that's a good question. A lot of times I'll have people model for me. I'll use just what I know to kind of pose. And that's the interesting thing. So we see these kind of bodies in medical illustration that are not actually reflective of our population. The world we live in is very diverse. So actually, in those cases, I don't really refer to previously done medical illustrations. I'll have someone that I know kind of pose for like the body shape or size or frame or like the skin or whatever. And then I use the anatomy text and other references for the actual anatomy.
You're creating new reference points. Yeah. Questions?
How much, sort of a two-parter, how much anatomy did you take when you got into this? And in your work, do you tend to go back to text, or do you look at CT scans and MRIs in terms of defining those small areas of anatomy?
Yeah, so when I studied medical illustration graduate school, it was a 2-year program at USC, and that was like my academic training and studying of anatomy. Outside of that, now I use like textbooks that I have and stuff, and in particular projects like the one I showed of the trigeminal nerve in 3D, we did get access to CT scans and CT data, which was very helpful. And so when I was working at the medical school, it was nice to be able to work with doctors that could provide me with that material. I don't really have access to that now, working just for myself, but when I was at the medical school, I was able to use data like that. And now for the most part, I'll use like anatomy text, netter. I have a couple of netter texts, so yeah. Yes, another one more.
I know you mentioned your own company and that you started at once, but now what do you need long-term yes, the long-term
Yeah, I started it just because it was something I wanted to do for a long time. It was always a dream of mine to own my own business. And I think that in the future, I would eventually like to get to the point where I could grow it outside of myself and maybe hire some medical illustrators to work under me. But for right now, I'm kind of just starting it and seeing how it evolves. But yeah, I think that would be my long-term goal, involve others. Thank you.
Thank you. We'd now like to introduce to you our last speaker and symposium co-chair, Ian Suk. Ian is a professor in the Department of Neurosurgery at Johns Hopkins University with a joint appointment as Art as Applied to Medicine, who specializes in imaging complex neurological surgeries for various medical journals and textbooks. He also teaches graduate courses in medical illustration, and his didactic and beautiful rendering truly encompass the realms of both art and science. His work has been published in 50 medical textbooks and over 140 peer-reviewed scientific papers, of which more than 50 were featured on the cover. And his work has won numerous awards from the Association of Medical Illustrators. He is the first medical illustrator to attain the rank of full professor at Johns Hopkins since the inception of this specialty in 1911. His presentation today is illustrating the unseen in complex neurosurgery.
Thank you for that wonderful introduction. First of all, thank you, Dean Rozoff, for inviting me here today. It's a tremendous honor to be speaking a medical school named after one of the greatest medical illustrators in history of mankind, right? One of the gold. So today, my talk is illustrating the unseen and complex neurosurgery, and the operative word here is unseen. So what is humanism? So for the sake of simplicity, I'm going to equate and synonymize humanism with Neoplatonism. And Neoplatonism in the Renaissance was the dominant intellectual movement that aimed to use ancient Greek philosophy to understand the current Christian, Judeo, ancient Islamic, and mystical concepts. It's named after this man here. Can you all see my pointer? Okay. It's named after Plato. And Plato, as you know, is one of the forefathers of Western philosophy. But credit should be given to this guy, Plotinus. He lived about 600 years after Plato. And he was the one really instrumental in synthesizing and amalgamating all the ancient Greek philosophers' knowledge into a comprehensible unit to feed to the mass. Right? So here's a simple graphic outline summarizing some of the basic concepts of Neoplatonism. It's basically comprises of 3 realms. In the uppermost realm, we have the world of ideas, of intellect, form. This is where mathematics and geometry reside, the recognition of beauty. So it was considered the world of the divine. It was pure, it was unchanging, and it was invisible. In the middle realm, we have the world of the soul, and in our soul, we have intelligence, reason, release, the perception of shadows and illusions. This world was also invisible, and it was unchanging. Now, in the lowermost, most basal realm, we have the world of images and shadows and reflections. Now, this world was visible and was constantly changing. So it was thought at the time that mankind's goal in life was to uplift himself, to ascend from the world of darkness and ignorance into the world of the divine and enlightenment, just by understanding, utilizing, and recognizing the main tenets from the upper 2 worlds. So this is a sketch that I did a while ago. It illustrates one of the iconic writings of Plato from his book, The Republic, Allegory of the Cave. So it's a dialogue between Socrates and Plato's brother, and it's trying to explain the analogy of prisoners who are, trapped in a cave their entire lives. They finally escape this world of darkness and ignorance into receiving enlightenment and seeing the truth. So here the prisoners, they're on the floor of the cave, they're chained by their necks and hands and feet to the floor such that they can only see one wall in front. Behind them is a roaring fire that casts shadows onto that one wall. And between them and the fire is a pathway for people and objects to parade through. So the prisoners see these moving shadows and they exist as the only reality that they know and understand. When they're finally free, they can turn their heads to see the fire. And at first, it causes their eyes being pained from the bright light. But they can finally see the true form, the true nature of the objects they were initially seeing, just as shadows. So, is there humanism in medical art? Of course, there is. This is a wonderful phrase that was published on my association website many years ago, and it stated, medical illustrators draw what cannot be seen, watch what hasn't been done, and tell thousands about it without saying a word. And the operative words here are drawing what cannot be seen, drawing the unseen. And in order to do that, this necessarily involves utilizing humanistic concepts, things like the use of critical thinking, use of good planning, use of good proportion, design, layout. They're incorporating naturalism into the drawing. Of course, having a good body of science, of art, of medicine, of anatomy to back up what you're drawing. It also helps to understand the pedagogy and the teaching aspect of the illustrations that we get. And last but not least, recognizing what makes things beautiful. So speaking of beautiful, the image on the left represents the perfect golden rectangle as devised by the ancient Greeks. It called it a golden rectangle because it uses the golden ratio. So if the short side of that rectangle is 1 unit long, the long side measures 1.618. It's an irrational number. It's rounded up to 1.618. It's represented by the Greek letter phi. And from here to here, this is 1 unit, this is where the golden ratio line is. It's considered magical line, right? So if you get nothing else from my talk today, know that some old guys in ancient Greece over 2,500 years ago can teach you how to take better selfies and better vacations. Remember your grade school and high school art teachers used to tell you, you don't necessarily have to put everything in the dead center of the picture. And say, put it askew from the center. How far askew, how far should you put it? Like the ancient Greeks figured this out. It's right here. It's literally this golden ratio line, right? So here's a simple way to pick this to pick that line. It's in the middle, it's between the third and the middle of any given length of rectangle. Okay. So here's the bisected line, right? Middle of the rectangle, here's a third way. That golden ratio line lies somewhere. Easy, right? So anyway, so even Leonardo da Vinci used ancient Greek mathematics to try to devise perfect proportions of man. So Michelangelo once said, a man paints with his brains and not with his hands. And this goes to the notion that knowledge precedes the application of art. So that was the classical definition of humanism. Today, Webster's defines humanism as a doctrine, attitude, or way of life centered on human interests or human values or ideals. So in medicine, this directly translates to things being patient-focused, right? And helping the patient care. So Netter used so effectively both the classical definition of humanism and the modern day definition. So many of his things. This is one of my favorite plays from the Sealer collection. It's illustrating angina pectoris, basically a heart attack. Netter's even listed out the 4 contributing factors: smoking, full exertion. So let's analyze this picture for a second. Where is the focal point of this? If you look carefully, it is right here. This pinpoint represents the gist of this entire figure. You guys clutching at his heart, right? Where is this line? Take a look at where this line is. This line is directly on the golden ratio line that I mentioned. Wow, it's really incredible. They use these effective diagonals, the angular lines, the railing, and the swoosh marks of the blowing snow to introduce action, to introduce dynamism in the illustration. Right? So let's go over the small details. Here's a drop cigarette, right? This guy's a smoker. He's exiting an upscale, well-heeled restaurant. It's not a taco stand or a hot dog vendor. It's an upscale restaurant where he presumably had a very heavy liquid meal, right? And look at the temperature differential. There's that warm, vast glow emanating from inside the restaurant versus a little snowstorm, a snow blizzard that's going on outside. And he's climbed the set of steps, right? Carrying this seemingly heavy briefcase. So he's exerting himself, his heart is racing, his heart is pumping. And take a look at the handiness of this guy. He's carrying that heavy briefcase. He's a left-handed person. 85–90% of Northwesterners are right-handed. Why would Netter pick a left-handed person? From an artistic standpoint, it would be more visually dramatic to have that right arm go across the chest, touch at the heart, which is eccentric on the left side. Also, by doing that, we can have the patient drop that heavy briefcase with his left hand. That outstretched left arm perfectly mimics pain and setback. It's that classic textbook definition of crushing retrosternal pain radiating into the underside of the left. So let's take a look at this briefcase. This is not a small, European portfolio that he's carrying. This is a Mondo case. It looks like he's carrying 20 pounds of paper and folders home, right? Netter is suggesting a lifestyle. This guy is taking work home. Netter suggesting this guy is overworked. He doesn't seem to be at the pinnacle of fitness. Netter suggesting implying that this is a long progressive disease, not once the blue event. This has a long etiology that culminated in this one spectacular event. So as an artist, in a singular panel, he had to deal with compressing time and compressing clinical factors, compressing the anatomy, physiology, but above all else, look at the expression on this text. When you're having a heart attack, it's not, it's not, this expression is not just one of agony and pain, there's a tremendous sense of bewilderment and surprise, right? So if you're saying, what is going on, what's happening to me? And in my opinion, this is what separates matter from all others. The sense of humanity, empathy, he puts back into the patient so many of these situations. So speaking of compressing time, I also tend to take this pictorial approach, this idea of being able to compress several different steps into a comprehensive figure. But I think it's at the heart of a lot of great surgical art. This was a vestibular schwannoma case. The green arrow represents the surgical viewpoint and the surgical access to a suboccipital rectal sigmoid craniotomy. The figure on the right represents much closer to what the neurosurgeon would see, but I added much more of the anatomy around that tumor. I really wanted to add much more of the neurovasculature surrounding that tumor. So here's another one of the figures from that series. So it's so you're inside the posterior cranial fossa, right? You're against the left wall of the skull base, directly in front of you is the tumor. So it's almost an impossible view, right? It's like looking through a landscape panorama. If you look up, here's the incisor of the tentorium, there's the posterior primary process, thyroidal artery, there's your clivus. And if you look down on the floor, you have the foramen magnum, the cut spinal cord. On the left is the sigmoid sinus, and here is the semicircular canals and the cochlea embedded in the temporal bone. So I essentially removed the entire brain and brainstem so I can clearly show the neurovascular anatomy surrounding it. So next case is a thoracic outlet syndrome case. This is an impingement type syndrome where the brachial plexus is essentially pinched or compressed by its surrounding anatomy. So the goal was to remove resect part of rib 1 in order to decompress the brachial plexus. So it's a bit of an unconventional approach. So the incision is medial and inferior to the axilla, and care was taken not to disturb the axillary lymph nodes nor the intercostal brachial node. The reality is, this is what you see in the OR. There's not a whole lot for the illustrator to see. So you're looking at the patient's left underarm, head is over here, the patient's left arm is over here. Half an hour later, this is what I saw. There's, I guess, again, not a whole lot for an illustrator to see, other than to note that the neurosurgeon actually took some time in the beginning to do some initial lung dissection, just using his fingers alone. You can imagine the attending, trying to teach the resident, what landmarks to feel for, what to pull and tug at the adhesions and so forth. I mean, to me, this sort of epitomizes this apprenticeship-based education we have in medicine. It's not something that can be easily taught or learned through just videos and pictures. So this is one of the intermediate figures. The surgeon is using longeurs to nip out piecemeal part of that first rib, again, to decompress the plexus. This is one of the main figures from that series. So it's an anterolateral view looking up. It's a worm's eye view looking up. The green area denotes the total amount of rib 1 that was resected. But what I wanted to clearly show was the coronal anatomy from front to back. So we would have the subclavian vein, then we would have the attachment to the anteroscleral muscle, the artery, brachial plexus, and the attachment to the neuroscleral, right? All in the context of showing that all important rib 1. So next case is an en bloc cervical chordoma resection. So the patient presented with this large cervical tumor. It was actually anterior and eccentric to the right side, involved 3 cervical vertebral levels, C2, 3, and 4. Here's the axial section. This is all tumor. All tumor. Here's part of the vertebral body. Here's the spinal cord. Tumor completely encased the vertebral artery on the right side. So it's a very lengthy 2-stage operation. The surgeons initially going from a posterior aspect. So we first remove all the posterior elements of C2, 3, and 4 vertebra. Here's the tumor that's poking through. You can see it's completely encasing the vertebral artery here. Unfortunately, they had to sacrifice 3 nerve roots, C2, 3, and 4. And then the patient was instrumented from occiput all the way down to T9. So the actual specimen is removed en bloc from the anterior approach. This is the past specimen. It's a sagittal section. You can clearly see the vertebral bodies of C2 and C2. So here's the anterior procedure. This is called a transmandibular circumglossal retropharyngeal approach. So transmandibular means it goes through the mandible, split the jaw, retracted laterally. Circumglossal means it goes around the tongue is reflected to the left side. And this dashed line represents the cuts through the posterior pharyngeal wall. All with the goal of accessing the upper cervical spine. Here's the intraop fold, and you can see the cut through the mandible here, retracted out laterally, tongue is reflected to the left side, part of the tumor poking through, and for anatomic reference, here's the carotid pictures. Here's the past specimen, measured about 7 centimeters across by about 9.5 centimeters. Here's the intraop reconstruction. So the patient is initially missing the upper part of the neck, essentially, after the tumor is taken out, right? So the surgeons used a titanium cage, just custom cut it in place to bridge that huge gap between C1 and C5. There's one screw at the C1 level and 2 screws at the C5 level. This sliver of tissue contained the lingual nerve and the hypoglossal nerve, which were very important. So here's the one of the main figures that summarize the anterior part of that procedure. You can see the jaw split here, retracted out laterally. Tongue is reflected to the left side again. And here's that titanium cage that was custom cut. The surgeons actually left the bends of C2 intact, along with the ligaments. So this singular screw at the top can have a much deeper purchase. And 2 screws at the vertebral level of C5. Here is the lingual nerve, and this is the hypoglossal nerve of the. So here's a close-up of that reconstruction. You can see how the surgeon cleverly cut this titanium tube to make that structural framework to graze the anterior part of the cervical spine. So here's the singular screw at the top. It's a tricortical purchase, so it goes through the entirety of the anterior limb of C1 and through the anterior cortex of the cranius. And again, 2 screws at the vertebral body of C5, 3 nerve root sacrifice on the right, and the vertebral body here as well. So these are the pages of the manuscript as it was published. We were actually very pleasantly surprised at just how much real estate was allotted to the figures and illustrations. So the final case is a total sacrectomy through an all posterior approach. So the patient presented with a large sacral tumor. The patient's semi-prone at this point, semi-seated and prone position. Here are the buttocks, the anus would be down here. It's a spinous process of lumbar vertebra. This is a posterior iliac crest. So the goal was to remove this entire tumor all from the back. So this would be a typical case in the OR. Here's the main neurosurgeon. She is a colorectal surgeon that came to help, a scrub nurse, chief resident, and there's the lowly investigator in the back. Actually, the lowliest person is probably the one taking this photo. Yours truly. So next series of slides I'm going to go through fairly quickly. And I think it'll give you a good idea how I go about in a step-by-step fashion rendering these complex figures using this layering technique. So this was the final sketch that was approved by the surgeon. You can see that bone hook making that final extraction of the entire specimen en bloc. Here the cuts through the sacroiliac joint and a cut through the L5S from this space. The scissors is making the final cut through the internal iliac calcium. So here's a shot of my drafting table. It's a backlit table. I typically just use graphite on translucent vellum. I typically draw different systems on different systems on different. For instance, the spherical system on one, the nervous system on another, maybe the vascular on another. And I would stack them and register them by drawing in these small clusters. And with the backlit table, I can typically see through about 3 layers of vellum. And then I would scan these in individually and digitally decompile them using Photoshop. So these are all the drawings for that comprehensive figure. It comprises of between 8 to 10 separate figures. Again, you can see the small hairs that I used to register. So first I rendered the entire stereotypical specimen. There's a close-up, you can see the cuts through the circular ligaments. I added the anterior sacral vessels. Next, I rendered the skeletal framework. Then I tackled the rate vessels. And you can see the surgeon making the final cuts through the internal ligament. First, I rendered the arteries. And then the veins. And then the sigmoid colon and rectum. Also. So this is what it looks like when the two systems are turned on. You can see where the colors overlap. Here, right? You get progressively darker here and over here. So the thing to do at this stage is to mask off and knock out part of the colon here and mask off part of the vasculature on the far side in order to give the illusion that colon fits inside this essential bowl of vessels. Also, so this is what it looks like when all three systems are turned on. You can see the skeletal framework, the vasculature, and the colon. Next, I rendered the spinal cord and nerves. So this is what it looks like when all the systems are turned on. You can see when I turn off the skeletal framework, you can see where I've masked off the colon and the vasculature here, and I've masked off the neural vasculature up here, again, to give the illusion that all those structures are anterior to the skeletal framework. So at this point, it's almost finished. That I'm putting that purple arrow to really emphasize that final extraction of the entire specimen in one piece. But I also realized that purple arrow actually obscured some of the critical elements on the far side. So I redrew that arrow, made it smaller, shifted it over, and I can clearly see the important cut vessels on the far side. So whenever I'm dealing with a complex image that involves many layers, there's a lot of tweaking, adjusting, and revising that goes on during the process. And this is how it was published. This is the final piece with the labels and meter lines in place. The black arrowheads denote where the sacral nerve roots were cut. Here's the intraoral folder. You can see that bone hook on the superior end plate of S1. There's bilateral cuts through the sacroiliac joint already made, and the surgeon is making that final extraction. And this is how it was published in the manuscript. These are some of my other figures that were published as cover articles in various journals, and I think each one of these can serve as an example showing the thought processes and the critical thinking that goes into illustrating the unseen in that complex illustrator. So with that, I thank you very much.
I have a question.
Yeah.
In reference to the operation for the tumor in the neck that you illustrated, how is your illustration in the article more helpful than a video of that operation?
As you may know, in a lot of this situation where the incision is very deep, gets very bloody, especially for, I guess surgeons can see the differentiated tissues much better, but there's a lot of bleeding in these massive type operations. So yeah. Does that answer your question?
So in a way, the illustration is more helpful than a video, because with a video, you're not going to see very much because of the blood. Is that what you're indicating?
Yes, it's very bloody. Even in photos, for some reason, the red spectrum of when you're taking a digital photo, the red spectrum tends to flare out more, so it just becomes very bloody. Video is obviously very helpful. Video is great because it can keep chronological track of what went first, what instruments were used, and so forth. But yeah, it's similar to a photo. Sometimes it's very important.
Ian, your work is breathtaking. It's really stunning.
Oh, thanks.
I'm really interested in the process, and I love that you showed us your process, and I noticed that you drew by hand on the translucent vellum first.
Yeah.
Is there any, do you feel that, you know, in a field that's moved very digital, what about that process to you? Why do you retain that process, the by hand process, which I, you know, being fully honest, like
Yeah.
more?
Well, there are a couple of reasons. I'm not that well versed in 3D and 3D animation, but even if I were to get a good data set, for instance, the vasculature in the sacrum, it's really hard to get a good simplified version of vasculature, period. So each vessel that I drew in, I literally had to look up the anatomy book. If I can get AP view, if I can get a side view, I can make it up. I can draw a 3-dimensional. I mean, it takes a lot of work. Yeah, but I mean, there's a lot of programs out there that you can buy that have the vascular, the nerves, the skeletal system, but I feel like a lot of them are oversimplified in a way, and they tend to look a little too homogenized.
Have to echo that word, I think captured it for me. Like I'm almost speechless. I didn't even, throughout that presentation, really your work is breathtaking. I had a question about process as well, and speaks a little bit also to one of the illustrations that we showed, blepharoplasty. How do you capture? Do you ever go into the surgery, touch, feel yourself, so that you can really capture that texture? Like I was thinking of that suture going through the adipose tissue and things like that. Like how hands-on do you get so that you can really represent it?
Yeah, as part of the grad courses, you always go into the OR and you draw a number of different cases. And this is essentially what you learn in the medical art training programs. You learn about tissue reaction, you learn about depth of field, you learn about the different types of instruments involved. Yeah,
Do you get hands-on?
I've been asked to scrub in a couple just for me to check things out, but we're usually no. The surgeons that I work with, they're very accommodating. If there's something, if there's a new procedure that they're doing, they're very accommodating and happy to allow me to take a look at what's going on. But usually the procedures that I attend are very long, so they'll often call me in at the opportune time. And usually, a lot of the times the approaches are the same. They may take hours and hours, and they'll call me in to see a case.
So you described well the potency of blood and of red pigment and visible light to obscure what's actually going on the surgeon. I'm wondering if you've had a chance to interact with different video-based technologies, looking at different wavelengths, infrared, dye-enhanced use of video. I think there's going to be an incredible opportunity for collaboration between medical illustrators and really some of the enhanced video enhanced modalities for surgeons.
Yeah, I know exactly what you mean. I know in neurosurgery, one of the big things that they're trying to push is dye enhancement, particularly for tumors, because a lot of tumors are very infiltrated. It's hard to figure out if you had good margins and whatnot. It's just and seeing glowing paint solves that problem. But I don't know to what extent that is used at Hopkins clinically. I can't tell you, but as far as helping the medical illustrator, anything helps. That helps us visualize would be a benefit for us. Going back to what somebody mentioned about would it help to looking at anatomy books. I don't know if you remember the body rules exhibit long ago. So I remember seeing the vasculature of the entire head, and it was basically injected latex, I believe, and it had the perfect shape of a brain, but just with vessels. But there was so much, it was so dense, you could not even make out, for instance, the internal carotid. I mean, it's just so. That's, as illustrators, that's what we're supposed to do. You have to tease out all the noise and get to the point, right? That's, so, when that was my point when you're using some of these, real scan data, 3D data from MRIs. It's just too much noise that we would actually have to spend a lot of time cleaning up. I hope that makes sense.
Seems to me that accuracy is so critical in medical research, especially from the point of view of medical education. Are there any examples where the art or the craft or the science of it has been used, where people have misused it for the purpose of spreading misinformation? In every other example of anything, there always is an example of that. And I wonder if there is a medical illustration.
There's, I don't know about if it's deliberate or not. I recall somebody in my association gave a lecture on the when something wrong or something has been depicted in an incorrect way, but that's the only thing that you have as a reference. Like a lot of people would copy that, and you make the sort of the same mistake, right? And one of the common things I remember mentioning is like if the bladder, a lot of editorials would picture urine in the bladder, just as if like it's in a golden, like a fish pond, right? It's never like that. In a real bladder, it's just the bladder shrinks to whatever capacity of urine is in there, right? There's no like level point. But it's always depicted like that. But that kind of thing. There's a lot of sort of copyright infringement within the medical art field and so forth. But I don't know if anybody does it deliberately to see. I don't know too many about that. One of my professors in Toronto used to say, if you use one piece of reference, it's called plagiarism. If you use two or more, it's called research. And there's a lot of truth to that. Thank you.
Before we break, we've actually concluded the medical illustration symposium portion of today, and before we break, we have a little bit of time. I would love to open it up to questions for any of our speakers today. I know I'm sort of thinking back, the more I learn, my mind has been completely expanded and open today to the breadth of this field, for which I knew embarrassingly little. And seeing the unbelievable range of what is possible, it's really amazing, and realize how much we rely, I think, on our profession as well. So I know I'm thinking back to earlier presentations. Is there any questions that anybody has of any of our speakers, Dr. Pilgrim?
So I don't even know if this is specific to anyone, but just thinking about teaching medical students, right? Teaching the anatomy, teaching the physiology, right? And I use a lot of figures, right? And I often have very little text in any of my slides, right? Because that's how I think, and how I think anatomy should be presented in medical school. A lot of comments from students that they need text. Do you have a method of teaching sort of in-depth visualization? Just, we sometimes teach, in-depth reading, right? Or in-depth text. Do you have any tips or tricks for teaching, that very visual learning from illustrations?
Hi, so it's part of what I do in the residency program is we, for our medical humanities curriculum, we have an info of lectures during the year where we approach a painting that typically has some sort of medical theme, though isn't always a person with a very, visualized illness. And I think a lot of it comes down to giving people a little bit of time to approach the work. If you're talking to an audience of residents in my case who maybe haven't spent a lot of time looking at art and thinking about art and trying to describe what they see, it's visually more than anything else, allowing them the time to just, and the space without judgment to just experiment. What do you see? What can I do? What do you take away from this? And you'd be surprised how insightful and how sophisticated some of the responses we get.
So that's transfer, right? Those
Yeah.
are transferable skills.
Right, and then what my expectation is that once they're able to talk to me about what they think is going on in the painting, everything from the actual stylistic choices of the artist and their painting technique all the way down to what narrative is being portrayed. Then the next step is take that to your physical exam. Don't tell me they have a preferred rash, tell me what the rash looks like. And how much more helpful that is for the next person who's reading the note to see a meaningful, thoughtful description, even if you don't feel like you're speaking doctor speak. And I think that's one of the first step, at least I think.
I just wanted to piggyback off that. I think, for better and for worse, at the medical school, there's this unfortunate fear of being wrong or being different. And I think there's an element of type A mentality. I came into this school kind of with my shortcomings on my sleeve, and I kind of was like, well, I'm the weird artist, I'm the wacky kid, so I would draw everything. But I think my colleagues, even if their drawings weren't good, were benefiting from drawing, especially in anatomy, especially when you're illustrating something abstract like Bible illustrating. And kind of creating a space, like he was saying, where you're welcome to do so, and where you're not being graded or judged in the product again, in that process.
I think that also is very beneficial and very much about art of uncertainty in teaching anthropology and medicine and giving that space to just exploring and know that don't know everything.
You're a phenomenal educator if you're educating on the ambiguity, because with every year success of my education when I was attending, we are taught in multiple choice exams that are black and white with the correct answer. And I found over and over again, there's much more gray to medicine.
Thank you. Other questions? Shoot back, yes.
This is just in general, for what you really want to answer, but do you feel drawn to another subject matter? And do you find that your experience with medical illustration transfers to that or vice versa? Like, do you paint something else?
I would say for myself, the other thing that has kind of come into my sphere of influence recently has been, it's still sort of medical adjacent, but it's not like public health. Public health and global health is sort of goes hand in hand, but it's relatively something that I haven't been involved in as much before now. And more, I think people are stressing the importance of public health, educating the public, and global health. So that's another thing. And outside of that, really, I mean, I'm just such a art and science nerd. It's so all I can think about.
Just a comment, and this really was an eye opener for me, for somebody who just can draw like a stick figure, and or like a butterfly out of a fly, I mean, that's like my big thing. I'm a pediatrician. So, a lot of times, besides talking a lot, I draw a lot, and then to help parents understand, like, for example, how to use a spacer with an inhaler, or like if I'm trying to teach a child, like what's going on in their lungs or what's going on in their belly or whatever, but I like also, the comment that was made by one of the speakers about perspective. And that's really been important for me with my patients and teaching medical students in my practice. Like, first of all, I teach them everything is gray, and the same thing what you just said is that, I'd assume this is what you have urticaria. I said, no, that's a diagnosis. I said, what you need to do is you need to put down a description. It doesn't matter how you say it, but red, blotchy, eruption, whatever the case may be, but you have to use the descriptive terms. And I've learned a lot of that from my kids, my patients, Because kids don't know terms, so they're gonna tell you, they're gonna draw you a picture with words. And sometimes I'm even lucky enough that they'll draw me a picture. And that a lot of times can help me understand what's going in their heart, their mind, whatever the case may be. So I'm just like blown away by all of your abilities to picture that. I can't picture in 3D. That part of my brain never developed, which is okay. But, hopefully I have other gifts, but I think that this is really something that I think needs to be, really portrayed in a much broader light in medical education and in practice. That, bring to a picture does really bring to light a lot of things. And I think one of the speakers said, if you take the time, you draw a picture, you show a picture, I go get the derm book. Somebody has tinea versicolor, I go grab the derm book and say, look, you're not the only person that has this. And I think it really takes your patient interaction to a whole nother level. So thank you, all of you, for opening our eyes on that and having all this stuff out there available that we can use. I mean, a lot of like the comics and that, my teenagers just love that. Because you tell them like, go read a book. I'm not doing that, but if you tell them go read a comic, or graphic novels, like little kids are like into graphic novels. And I think even adults, they're not all, highly intellectual in the medical, jargon. So I think pictures can really 8,000 words. So thank you, everybody.
Yes.
My name's Bill. I'm a professional medical illustrator here in Connecticut. My company specializes in 3D medical animation. I went to the medical school illustration program in Dallas, Texas at the University of Texas Southwestern Medical School. My wife, who I met at a medical illustrators meeting, went to the University of Chicago Medical Illustration Program. There's not that many of these programs around. They're all very particular who they choose. So my question is an overall question, for the faculty, maybe people like Dr. Collier. Have you considered establishing a medical illustration program here at Quinnipiac?
I think that's a great inspiring lecture. The answer would be yes, but in a really more concrete way, what I would hope to say is that I think we have such a tremendous opportunity to expand the portions of our curriculum that are at the intersection of art and medicine. I think we've heard and seen so much today, not only about how more engagement at that intersection increases skills of empathy and of observational skills, curiosity, but also what has really resonated as I listened to the question and answers and looked around the room is this whole piece of ambiguity, which is really so central to what we engage with on a day-to-day basis as physicians and as educators. So I'm really excited to see where we go forward in the areas of visual skills, visual thinking strategies, and ultimately, who knows, maybe more engagement, but we'll always be anchored to our namesake, Dr. Frank Netter, and the incredible way in which his humanistic and empathetic drawings connect to our patient-centered model of medical education. Thank you.
This day has been filled with such remarkable talent and learning and new perspectives. I would love to ask everybody to join me in one more round of applause for all of us. I just want to give a special thank you to Ian Sook and Francois Lux, who co-chaired this and selected the unbelievably talented speakers and the breadth to represent so much of medical illustration. Thank you both so very much.